and a very good morning to everyone. Moving on to the second part of the breakfast at UMHealth session. I am Chaw from the Department of Anaesthesiology. Will continue to moderate this session. First of all, let me introduce the speaker, Dr. Iftitah. She is a clinical specialist in UMMC for the past 7 years. Apart from her general anesthesia specialty, she is also currently under training for subspecialty of pediatric anesthesia under the guidance of Professor Iftitah. Her current special interest is hypothermia in pediatric population, of which a study of this topic is ongoing in our department. Without further ado, let me welcome Dr. Iftitah to talk about perioperative hypothermia in children, the 4W and 1H.
Good morning, everyone. My name is Iftitah. I'm from the anesthesia department team. So without further ado, I'm going to start my presentation. Oh, wait. This is right. Can you see that? No. Right. Okay. So my topic is perioperative hypothermia in children, the 4W and 1H. The what, where, why, how, and where. So these are my outlines. What is perioperative hypothermia? Why is it important? How and when does it happen? And where are we on this? So what is perioperative hypothermia? Just a brief introduction. This is a paper by Simon Roch et al. In 2021. It's a narrative review. So the definition is an unintentional hypothermia, defines as core temperature less than 36 degrees, pre, intra, and post-operative period. Right. So in the BJA in 2018, C. Riley and Andrzej Jowski presented a very good paper on inadvertent perioperative hypothermia, which essentially is the same, and it is also defined as core body temperature of less than 36 degrees. So what about in children? So Marcus Neffmuth et al. In their narrative review of perioperative hypothermia in children defines the temperature of less than 36.5 degrees of those of less than 5 years old, but more than 5 years old is less than 36 degrees. So let's talk about incidence in children. So in 2014, JNIC clinical research paper by Pierce et al. Had a good number of patients of 530, which they had 52% of incidence out of this population. So that's quite a high incidence. And this is up to date, the biggest data that they have by NSQIP, American College of Surgeons, had 6,000 plus patients and their incidence was 45%. So what about other papers? So these are papers by Sim et al. In 2010 saying that they have 85% incidence in premature infants undergoing laparotomy. And Chui et al. Had 82% of incidence in 249. So I think it is very important. So why? Why is it important? It has been shown that it causes coagulopathy, increase in blood loss, increase in transfusion requirement, increase in surgical site infection, and delays in metabolization of drugs and delays in PACU discharge. All these are negative effects proven and established in adult population. And all this because of decreased blood flow. Surgical site infection are caused by decreased blood flow. Drug metabolisms are reduced, especially in anesthesia. Our gases and our muscle relaxants are reduced, and all this causes delayed recovery. increase in bleeding and transfusion requirements, secondary to impaired platelet function, impaired coagulation cascades, and all these increases in the relative risk of transfusion, and increased rate of cardiac events, and also increase in shivering. So what about in children? Do you have papers in children? Yes, we do. The NSQIP says um, out of the 45% of the children, most of them had surgical site infections, wound disruptions, unplanned return to hospitals, and increase in transfusions requirement. The JNIC had greater blood loss, greater transfusion requirements, and they are more prevalent in invasive procedures, older age children, and longer duration of children. So let's talk about how and when does it happen. For this, we have to understand the thermoneutral zone term, the physiology of thermoregulation, and the anesthetics and the thermoregulation principles. So what are thermoneutral zone? It is a range of environmental temperature in which the metabolic rate and oxygen consumption secretly is minimal, and thermoregulation is maintained by vasomotor activity. So as you can see, a dog clothed had a higher temperature thermoneutral zone where there won't be any vasomotor activity or even behavioral if outside of anesthesia. But for neonates and full term neonates, it is at a rather higher temperature. A full term at 32 to 34 degrees, and at even lower birth weight is at 35 to 36. So so a little bit on the physiology of thermoregulation. Um, the temperature are received via the fibers in the skin and deeper tissues, and go up to via the spinothalamic tract, goes to central regulations, and then it will be integrated in the hypothalamus. It compares with the threshold temperature, and after that there will be a response via behavioral or autonomic. So yeah, so in what about in anesthetized patient? So looking at this diagram here, um, the difference in thermoregulatory thresholds in awake and anesthetized patients. If you can see at my diagram here, um, in an awake patient, the interthreshold range is very, very tight, and it is only between 36.5 at most to 37.1, whereby in an anesthetized patient, it is widened up to 4 degrees. So for the body to preserve this interthreshold range, the body has to become really, really, really hypothermic to initiate an autonomic response. So so in the operative theater, we have a physiology where the first hour of after induction, redistribution happens, which we call a phase one. Here the temperature drops about 2 degrees in about 1 hour. Warm bloods redistribute to from core to peripheries, essentially due to vasodilation and due to our anesthetic gases and drugs. Then over the next couple of hours, 2 or 3 hours, it drops further another degree. This happens when heat loss exceeds heat production. And the third is when plateau, heat loss is matched by metabolic heat production and falls slowly. So knowing this mechanism of heat loss. Mechanism of heat loss are essentially only via 4 mechanism: convection, conduction, and radiation. radiation, and adults, essentially, it is mostly by radiation, but in children, it is mostly radiation and conduction. So, uh, this okay. So I will go further. So, this via this mechanism, what are the causes of this mechanism that causes the loss of temperature? Usually a cold room in the cold room of the operating theater, the motion of air or fluid, drying of wet skin, respiratory losses, and contact with cooler objects. So what do we want to do? We usually do warm room cover the patient, and then through convection we cover patient. Through evaporation we warm the skin prep solution, warm and humidify our gases, and then we use forced air warming circulating water blanket. So why do pediatric loses more heat than adults? So we all know that children has higher body surface area to volume ratio. Okay. They have less insulating subcutaneous adipose tissue. They have higher basal metabolic rate. They have immature hypothalamic thermoregulatory capacity. They have high resting vagal tone, so are less able to vasoconstrict and keep their heat. Their shivering mechanism is poorly developed, and their most important is they have limited non-shivering thermogenesis. So this diagram is a beautiful diagram showing how and why is it important in children that we need to protect their heat, to keep their heat. All this cold stress with all this physiology increases their catecholamine response, reduces the surfactant production, increases in the vasoconstriction, and increases the metabolism, which all in all causes increases in risk of hypoxemia, acidosis, and hypoglycemia. So, now, what is recommended? So, in the NICE guideline in 2016, but this is an adult guideline, we should attain first the risk factors for patients that have the risks of inadvertent perioperative hypothermia. So those with ASA grade 2 to 5, the higher the grade, the greater the risk, and then the preoperative temperature of less than 36 degrees, those that undergoes combined general and regional anesthesia, and those undergoing major or intermediate surgery, those with at risk of cardiovascular complications, and those with low BMI. So what about children? So here in the BJA, C. Riley et al. Recommended these are the risk factors: those of young age, surgery of more than 30 minutes, major surgery, and temperature of less than 36.5 before induction. So these are the high risk children going for operation. In the Nemeth et al., what are the recommendations? So the recommendations are generally to maintain normothermia during transport, to have an active warming throughout intraoperative procedure, to have an active warming at induction, and of course we have to have an accurate measurement of core temperature. So how do we measure core temperature? This is what is recommended by Nemeth et al. Preoperatively, an oral and axillary temperature measurement is adequate. Intraoperatively, it is recommended to use a continuous methods, esophageal, nasopharyngeal, a non-invasive ZHF technology. Unfortunately, we do not have this in Malaysia, bladder or rectal. And post-operatively, oral or axillary, and tympanic are those that we usually measure here in our center. So, so how do we prevent this in our setting? In what is recommended. So during transport, first we have to warm them during transport. If a child comes to the OT already hypothermic, even the best warming strategy proved inefficient. So we have to ensure they are clothed as long as possible. It should be covered in blanket, ideally a pre-warmed bed to prevent redistribution of heat. As for infants and neonates, they should be transported in incubator or with an attached radiant heater. This incubator should be plugged in to keep warm entire surgery. And then before we have to warm them before induction. So the OR is usually warmed prior to OT to temperature of a thermoneutral zone. But as what I showed earlier, thermoneutral in children and in infant especially is rather high. But then like for neonate, it is 32 degrees, and for infants, it is about 24 to 30 degrees. So to keep an OR up to this certain level of temperature, it takes 60 minutes to warm an OR. So that's a very lengthy time for us in the operating theater. But so what is recommended now is the temperature between more than 20 to up to 23 degrees if you are doing pediatric cases, which this will suffice, and this will still be comfortable for surgeons as well. We should start active warming before induction itself. So usually we would put a warmed underbody with a forced air warming blanket. And then we will only undress the children for monitoring and then insulate the uncovered parts. These are all done ideally before induction. And all this can reduce the heat loss by 68%. So next, we should do warming during anesthesia. During anesthesia commencing. So this it should be done and continued throughout the anesthesia and surgery. Right. So warming after anesthesia. The children should be continuously warmed until after anesthesia. So going back to the during anesthesia, how do we warm these patients? Besides the forced air warming devices, we also use warm irrigation fluids. Ideally, all cases should use heat moist exchangers to warm the respiratory airways. Infusion warmers, which are actually recommended to be used in adults above 500 ml per hour. But in children, usually we do not go up to 500 ml per hour. We go by mils per kilo per hour. So what is recommended is if you go up to 30 mils per kilo per hour in a children, you should start to use an infusion warmers. And especially so if there is a play for massive fluid and blood administration, those in major surgeries, abdominal, thoraco, and even cranial surgeries. Right. And also, I'd like to pay special attention to our dear colleagues, anyone who uses a infusion warmer should always pay special attention to use the warmers as close to the cannula to reduce the heat loss during the transition of heat loss lah. So yeah. And what about extubation? Do we extubate when do we extubate? There's no guideline or a recommendation when is the best safe temperature limits to extubate. But uh, but a child shouldn't be extubated when they are hypothermic. So just keep the temperature beyond 36 and extubate them to a warm environment and send them back to a pre-warm bed. Like, for example, if the child comes in an incubator, the incubator should be entirely warm throughout the surgery. And then if the child goes back to a trolley, the trolley should be warm prior. This core temperature should be measured regularly, even though the child has been extubated. So, like recommended before, we should check the temperature in the PACU itself as soon as the child comes there, and mitigate a proper response should the child still be hypothermic. So, this is a review by Shikman Singh in 2018 in a special editions of updates in anesthesia. Here she says that we should always keep the child warm, increase the OR temperature, warm the intravenous fluid, uses a passive insulation, and force air warming devices. So what are the warming devices that we use? We have fluid warmers and we have body warming devices. But with the many inventions of all these beautiful products and equipments, there's always there's always these safety precautions that we always have to think about. And I think all of our colleagues should already know about it. And the way that we use it is it depends on the surgical access, the ease of use of each of these devices, the bulkiness, the patient's positionings, intravenous access, and device performance. All of these considerations that need to be decided upon, and which equipment we should use. So but in all of patient, we try to use forced air warming device as recommended by the NICE guideline. When do we use it? Usually we use it intra-operatively, but in NICE guidelines, as said here, it should be used even before, pre, intra, and even post-operative warming to keep the temperature at 36. I'm going to show you how it looks like for those of us who's not working in operating theatre. This is the common bear hugger, a forced air warming by the bear hugger company. If you can see, this is how we use it in children and the body. And what do we? And this is our warmers, fluid warmers. The most the most effective are by far the hotline, and of course the level 1 rapid infusion system. We only use the rapid infusion system when we have massive blood loss, or we preempt patient, especially in those like cranial surgery, cardiac surgery, and also spine surgery. These are other examples of fluid warmers, Astopho Plus. It is a unique and quite beautiful equipment where we thread the infusion line. If you can see it, the picture C, we thread the infusion line in between the heating profile and keeps the temperature of the fluids that goes in. So I'm going to talk about, so where are we? Naturally, we in this pediatric anesthesia team, we would like to know how do we do in our own setting. So for the past couple of months, we have embarked on this perioperative hypothermia in pediatric population, a prospective observational study. What do we want to find out? We wanted to find out about the incidence of hypothermia in our own local setting. We want to know how do we use the perioperative measurements of temperature, and how well we use the active and passive preventive measures managing these children. So where are we at the moment? Currently, we have completed a data collection of 144 patients and undergoing a preliminary analysis and generating interventions such as local guidelines and also increasing awareness in our healthcare personnel. Challenges, of course, getting appropriate measurements in at the reception bays and in the PACUs and especially at different sites in remote areas like the MRI suites, the scope rooms. And during the analysis, we found many incomplete data. So I'm going to run through the results of our study. So these are our social demographic data. Sorry. We have quite comparable age group we have about quite what do you call this, comparable in each group of children. Mainly our type of surgery. Mainly we do patients in between ASA 1 to 3. And we have mostly male, and the samples are from mainly our inpatient. They were mostly elective. 94% are elective. Unfortunately, unable to catch much of emergency surgeries, and 66% are minor, 20% are intermediate, and 40% are major. So these are divided into surgery sites. Mostly our patients are undergone abdominal and head and neck surgery, and we have others as well. So what are the anesthesia technique that we have been used? 77% are only general anesthesia. 15% includes neuroaxial block. 4% only monitored anesthesia care, and 4% is GA with peripheral nerve block. So we use about 87% of pre-warmed IV fluids. I'd like this to be 100%, but yeah. Pre-warming patients, 57% does pre-warm patient, which is quite good. So how much do we use our intraoperative active warming measures? These are actually quite good. Most uses at least one type of active warming measures, bear huggers. Some use together with fluid warmers. But unfortunately, there are 10 out of our samples that did not use any active warming measures. What about passive warming measures? Most use occlusive covers such as autobans and cling wraps, domino plastic wraps. Almost all uses the heat moisture exchanger and warm blanket, but still there are 5 of them that does not use any passive warming measures. Do we monitor everyone? Almost all, except for 13 samples. Usually these are those of short procedures, short peripheral procedures. What about PACU warming? Do we warm them? Unfortunately, 27 out of all our samples does not warm our children. So let's go to our outcomes. What do we find in all this? So this is the groups divided to hypothermic and normothermic. At the blue colored is patients with normothermic, and the orange colored is hypothermic. At the receiving bay itself, we have 7 out of 144 patients that were already hypothermic, and intraoperatively it is quite high incidence. But in PACU, we have only 17 out of 144 that is hypothermic. So these are our incidents as of this preliminary analysis. At receiving bay, we have 5% of the children that is hypothermic, and at PACU we have 12%. Intraoperatively, I would say it's quite high, but this is relatable to the physiology of temperature regulation, whereby it will come down after the incidence will come down as the time goes, and in PACU, the incidence is just 12%. I would say we did quite not too bad. Right, so what do we do after this? These are our future plans. After assessing the current hypothermic situation, we plan to develop a local guideline. So our colleagues and then we will try to implement this and increase awareness in our personnel, and in the end we would like to reassess back the incidents and hope that we could have better incidents after this. I'm just going to show a preliminary our local guideline. We have divided to preoperative, intraoperative, and post-op management. It's all whatever I just said prior, and then yeah, I'm just going to show you guys how we do it in our operating theater in most of our pediatric cases. If you can see the top one, this is a radiant warmer that we use, that we prepare, that we set up before induction of anesthesia. And this is the forced air warmer. And the underbody warmer covered in canvas, and we also warm our orthoban here. This is an example of our recent patient. Patient is adequately covered intraoperatively, with the head is covered, the limbs are covered in insulating orthoban and cling wraps, and we use a HME to warm the respiratory gases. After we also wrap the child with abdominal wraps, and only the operative site is uncovered. These are other examples of this is our HME and other types of bear huggers, forced air warmers, and this is how we keep our forced air warmers. That would conclude my talk. Thank you, everyone.
Okay, thank you, Dr. Iftitah, for her presentation on intraoperative hypothermia and the updates on her ongoing study, which would be an important quality improvement project in our department. So next, we will welcome any comments or questions from the floor. There are some comments or questions from the Q&A chat. From Prof. Shereen, excellent point regarding importance of warming during transport. These include transfer from other hospitals and should be assessed in the ED before going to the ward to ensure temperature fluids are adequate. Yeah, totally agree on that point. From Prof. Tunku Sarah, looking at the various uses of warming devices, perhaps it should not be left to the individual, but have a basic SOP for warming all neonates and children. Any comments?
Thank you, Prof. Tunku Sarah. Yes, it is not left to an individual or the anesthetic. Hence, we have a local guideline to increase the awareness to all our staff in the operating theatre. But we would like to reach the ward as well. So we usually tell our colleagues to enforce these pre-warming techniques, such as clothe the child as long as possible, even before when they are in the ward.
Okay. Comments from Prof. Gang. Excellent presentation from both speakers, Dr. Hana and Dr. Iftitah. Last question from Prof. Shireen. Did the site of surgery impact your outcome? For example, some theatre locations, maternity are much colder than others.
Thank you, Prashant, for the question. As of now, wait, I don't know whether I can show you here. Hold on. What I've gathered that 3 out of the whole surgical disciplines has higher risk than the others. These are pediatric surgery, orthopedics, and head and neck surgery. But this is only preliminary data. I have yet to get the type of surgery that they do. I would expect a major surgery plays a role and would have higher risk. But yeah, my data is not yet finished.
Okay. There's also a comment from Prof. Azana. We never get 23 degrees in the theatres. Can we ensure intraoperative environmental temperature can be adjusted based on the patients rather than centralized? Okay, we always get the same answer when we request that the temperature be increased, that it is centralized. Yeah, necessary to prevent extreme hypothermia among high risk patients. Yeah, we agree on that.
Yes.
Prof. Azana.
Thank you, Prof. Azana. Yeah, excellent point there. We have been trying to increase our temperature up to 23 degrees. But I think at most what we've got from our data, the temperature at most is about 22 degrees. Our OT is not a centralized it is not centralized as in we could warm selected operating theater. But like I said prior, to warm a temperature in an OT, it takes 60 minutes. But we have showed from this data that warming a temperature up to this 20 to 23 degrees quite suffice, and patients are not that hypothermic when they reach plateau. And it is not only one method to warm the patient. So OR ambient temperature is, I agree that it's important, but all the other modalities are also important.
Okay.
I hope that answers the question.
Okay, thank you very much for all the comments and the questions. So I think it's time to wrap up today's session. Wrap up the baby to keep them warm and safe. So we will look forward to the ongoing result of this clinical audit, which I think is very important to look at our care to the pediatric surgical patients, as well as our future development of local protocol or guidelines to improve the perioperative care in our patients. So thank you for listening and have a nice day. Goodbye.
Thank you.
Thank you.